discussion or Q&A. As well, a copy of today's slides and the recording will be shared with you via email after the session. So thank you all again, and now we will get started. So our first speaker, who I'd like to introduce, is Dr. Laurie Theeke. Dr. Theeke is a professor and interim associate dean at the George Washington University School of Nursing. She's widely recognized for her work on loneliness and how it impacts health and well-being. For over 20 years, her research has focused on the connection between loneliness, chronic illness, and mental health, especially among underserved populations. She's also developed the Listen intervention and contributed to programs like I Belong, which are designed to help build meaningful connections and improve quality of life. We're excited to have her with us today. So please join me in welcoming Dr. Theeke. We also have with us today, who I'm pleased to introduce, Dr. Joseph DeSantis. Dr. DeSantis is an associate professor at the University of Miami School of Nursing and Health Studies and co-director of the Mental Health Disparities Core at CHARM. His work focuses on HIV, mental health, and the psychosocial factors affecting vulnerable communities, including people living with HIV, transgender women, and Hispanic men who have sex with men. He has presented nationally and internationally and published extensively in the field, and currently serves as deputy editor of Archives of Psychiatric Nursing. So please join me as well in welcoming Dr. Joseph DeSantis. So we will now turn it over to our presenters.
Okay, thank you, Nicole. And I can just share my slides. Is that what we're going to do? I sent the slides into Dree, but I
Yes,
guess I'll just,
ma'am.
okay.
Did you have the ability to advance your slides?
Okay, thank you very
Yes,
much.
ma'am.
Okay. All right. Let me see if I can share them. Does that work for everybody? Can you see the slides?
Yes, ma'am.
Okay, thank you. Okay, well, thank you for having me. Yeah, today we're going to talk, Joe and I, we've been colleagues for a while now, and we put this talk together. I am at GW and he's at Miami, but we have a common shared interest in loneliness, particularly in people living with HIV. So I'm going to talk to you a little bit about how loneliness is a health problem that impacts health overall and some of the research we've done in that area. And then Dr. DeSantis is going to cover some more specific information about HIV. See if I can get the slide to advance. Okay, the first thing I want to talk about, though, is how this research really got started and where it's rooted in human health. And I did want to make everyone aware that really loneliness is a problem that stems out of our very basic need for human love and belonging. And we've known of this need, of course, for 70 years, but healthcare providers and other providers normally don't take on planning for people who are lonely. So I started my work thinking about loneliness as a problem that stems out of the unmet need for belonging and how it is prodromal to depression and dysfunctional social behaviors and sometimes suicidal ideation. So I wanted to give you some information about loneliness across the U.S. and the globe. Loneliness is a highly prevalent problem. In U.S. Seniors, 31% or more often report themselves to be lonely. In some of our studies, we found that 17% of U.S. midlife and older adults, 20% of children actually, and in Appalachia, which is a region I've heavily studied, up to 90% of seniors. Social isolation and loneliness are different, which you've just heard about, and it's important to remember that. Loneliness is a perception, and it's very much based on how you perceive your needs being met as a unique individual. Social isolation is more about how many contacts you have per day and your access to other people, how much you communicate with other people. It's very, very much more quantitative about how much you can connect with other people rather than how you feel about your connections. The thing that's important, though, is to realize that in global studies, for years now, we've known that both of these situations are problematic. Both of them are independent conceptually, but are risky and have poor health consequences and also may shorten your longevity. So, in some of my work, we've looked at predictors of loneliness. In particular, we looked at some data from Health and Retirement Study, which is all older adults in the U.S. over age 50. And I wanted to share with you that we do know, and this has been repeated findings in studies, we know that people who have things like poorer social determinants of health, like poverty and low access to education, a high number of chronic illnesses, or unemployed, are more likely to be lonely. We also know that your relationship or marital status can affect your perception of loneliness. And then I think it's interesting that it's not just rural residents that sometimes are lonely. Sometimes it's urban residents that live in communities where they don't feel like they can get out, such as high crime rate communities or communities where they don't have access to enough public transportation. So people with these specific factors are at increased risk for loneliness, and that's important for all of us to be aware of that. I put these pictures on the slide because I've done a lot of work with older adults and children, and I wanted you to see the posture of a lonely person. This is an example of how sometimes lonely people will present, so that you can sometimes recognize them in a room full of people. And oftentimes they'll have a closed off posture. They may have head down. They may not make eye contact. And they do sort of have a different facial affect, which I've recently been looking at as well. Um, it's important to not only know that loneliness is a significant problem and what the predictors are to it, but some of my research has focused on a model of health I've developed that talks about how human beings respond to loneliness. And this is across the board, younger adults, older adults. We know that your body, when you're chronically lonely, and your mind does respond to that perception of loneliness. And it responds in different ways. It responds in biological, behavioral, social, and emotional ways. So we do know that loneliness is considered a chronic sort of, I call it a smoldering stressor, even though it's not like a super acute stressor. It does cause your body to have a biological stress response. And we do know from multiple studies that lonely people have higher inflammatory markers, higher circulating cortisol, and some altered brain function from a paper I just presented on the lonely brain. But in addition to that, we also know that lonely people are not just lonely. Then they have an emotional response to loneliness that causes other psychological problems. The three emotions we see most commonly in the research I have done have been worry, anger, and fear. So, like lonely people also have sort of this triad response of emotions, and those emotions add additional stress to a person, can change their sleep habits. They sometimes result in them being fearful about their own value. They can diminish their optimism and self-esteem. And the other thing I want to share with you is that lonely people do react behaviorally. So they often have irregular eating because eating can be a social event, remember? Sometimes decreased physical activity. And we do know that lonely people at different age groups are more at risk for different types of substance use. In my studies, I did find that older adults who did not have diagnoses of anxiety were more likely to use benzodiazepines. But also, I noted in Appalachia that lonely adults did smoke more, specifically tobacco, and it potentially have more opioid use, but they did not have higher alcohol use. As a matter of fact, less lonely people had higher alcohol use in those studies. And the other thing to remember about lonely people is that they have a social reaction to loneliness. There is a stigma of loneliness, and it's the stigma of social undesirability. And so lonely people sometimes don't feel like they would be accepted, so they tend to self-isolate, which is really problematic because it perpetuates this sort of vicious cycle of loneliness and isolation. So, in addition to the responses, we've done some work too on longer term health outcomes, and I just wanted to share that with you, knowing that lonely people often do develop worse chronic illness outcomes, like worse cardiovascular outcomes, higher rates of obesity and metabolic syndrome, actual psychological diagnoses such as anxiety, depression, suicidality, and then poor adherence to treatment or lower self management ability, which could be important in an HIV population as well. So I have been known quite a bit for the development of Listen. Listen is one of the things that I've studied in a way to help lonely people. It's an intervention that's more precise to loneliness, and it is based on two different things, story theory, but also the principles of cognitive restructuring. So Listen is like a group, a 5-session group intervention. And in the studies of Listen, we did find that people who participated were able to be less lonely. I do want to tell you that Listen is not a one-stop shop solution for lonely people. What happens in Listen is that people discover what they need related to their own unique experience of belonging and their capacity for connection, and they determine what actions they need to take to be less lonely. So, Listen is about self discovery and figuring out what you need in that moment in your life where you are experiencing loneliness. I did want to share with you just a few things we've done very recently looking at loneliness and Black women with hypertension in the United States. And this is again from big data set analysis for people 50 and older. And so these are some new collaborations we have going. In this one, it's not surprising that we did find that there's a triad of loneliness, depression, and hypertension in Black women. And the other thing in particular I want to say about this study and our studies of Black women is that we have focused on how current screening instruments may not capture their experience of loneliness, because we've seen in this study that many of the quantitative studies are reporting that Black women may not say they're lonely when they are lonely, which happens also in Appalachia, and they also may not perceive themselves to be able to express some of those negative emotions associated with loneliness. We've also done some interesting work with wound healing that could be relevant to the HIV population. Most recently, we've done some social genomics. And in this study, we did find that high lonely people were slower healers. They had larger wounds and more inflammatory and lower immune markers, and were less able to heal chronic wounds. So that was in line with our theories that lonely people have inflammatory responses and immune responses that make them less healthy. And so we're also doing some work on functional ability. And I'll summarize this for you just by saying that we know that older adults who are lonely do decline in functional ability. And we actually also saw in the studies of Listen that when lonely older adults were in the control group and didn't receive Listen, they continued to decline in function, but participants of the Listen groups did not. So that was interesting. And our final study I'll share with you is we're currently looking at technology-based interventions for loneliness for adults in nursing homes. And this is just something we're exploring because we do know that even high-tech or AI-enabled tools might help lonely people. So I'm going to turn this over to Dr. Santis now, but that's some background on loneliness for you.
All right. Thank you, Laurie. So I think, Laurie, you're going to probably have to advance the slides for me, right? All right. Thank you. I love having an assistant. This is great. So as Laurie said, we've known each other for a number of years, and we've had this idea of working on loneliness interventions for people living with HIV. And when I give this talk, I always like to start with some quotes from some famous people about loneliness, because loneliness, like Laurie said, is an age-old problem. It's been around way before HIV, but some very famous people, and one of the most famous, if you're aware of Franz Kafka, he said, loneliness isn't the absence of people, it's the absence of being understood. And I think that's a very, very powerful quote. And I think it's, it goes back to say that, people can be alone and not lonely, and people can be lonely and not alone. So I think that's a very important thing to keep in place. The next slide, Laurie, please. And continuing on, there's other people that talked about loneliness, other famous people, writers who talked about loneliness. And I love, the last one. I was with them and yet I was alone. So I think a lot of this has to do with, people living with HIV. As they shared earlier in my introduction, I've worked with people living with HIV for over 26 years, both as a nurse practitioner and as a researcher. And all throughout my time as a clinician and a researcher, I've heard a lot about loneliness in HIV. And maybe people didn't use the word loneliness, but they talked about some of the other factors that may have made them lonely, but maybe they didn't recognize it as loneliness. And maybe I, as a clinician or a researcher, didn't recognize it as loneliness. So this is kind of in a sense, a new and emerging area. And I think it's really something that really is worthy of looking at, not only in older people with HIV, and I'll talk about this a little bit in the future, but also younger people living with HIV. Because as Laurie pointed out, you know, loneliness is across the age spectrum. It's not only, people in nursing homes or older people, it's everyone, right? Next slide, please, Laurie. So Laurie pointed out earlier that loneliness was like 31% in the general population of adults, but in Appalachia, it was 90%. We know that there's a couple of classic studies that show that people living with HIV, about 60% of them are lonely. So it's higher than the general population. So this right here, of course, tells us that it's something that we need to look at in people living with HIV. Also, in studies with people with HIV, loneliness is a predictor of poor physical and mental health, and those people tend to die earlier. Okay. And they're not dying from HIV, they're dying from their poor physical and mental health that relates to being lonely. And again, I always like to talk about solitude versus loneliness because a lot of people like to be alone and a lot of people like their solitude, and that doesn't mean that they're lonely, but we always do have to keep that in mind. Okay. Dealing with students and patients all day long, when I come home, I just want some silence. I want some solitude, right? And so I think that, that's important for us to differentiate those type of things. I was going to put a slide in here, but for the interest of time, I'll just kind of mention it. When we understand loneliness among people living with HIV, not only do we have to think about a biopsychosocial model that Laurie kind of presented earlier, but we also have to think about intersectionality. And, people living with HIV come from, various groups that may be marginalized or may be isolated. And when you start looking at those different intersectional factors, they can pile up and increase a person's risk for loneliness. So, I always want to put that, plug in for intersectionality when you think about, HIV and loneliness, because some of these things, may put you, at risk. For example, if you're poor, as Laurie mentioned earlier, you're single, maybe you're sexual gender minority person, and then you're living with HIV and you're lonely, all of these things kind of compound together and kind of increase your risk for loneliness. But I like to talk about the biopsychosocial approach and understanding loneliness. And as Laurie said, when a person is lonely, there's a lot of inflammation going on, right? And we know that people living with HIV, if their HIV is not controlled, they have a lot of inflammation going on. So again, you get a little pileup of the inflammation from uncontrolled HIV and then the inflammation from loneliness. It's really going to accelerate your aging. All right, your cellular aging and your aging in general. So those are the things that we have to think about. I'm sorry, Laurie, back up on that slide. I'm sorry. So when we're thinking of the biopsychosocial approach, we're looking at mental health, mental health as part of the psychological, physical health, and the physiological effects as part of the biological processes that are involved in HIV. And then also, when we talk about the social, that's the social isolation and stigma. We have to talk about stigma when we talk about HIV. And a lot of times when I've seen my patients, both as a clinician and as a researcher, they would tell me things and they would say, "I've never told anyone this before." Okay. And I thought that was like really, really powerful because it's like that stigma really holds them back from being able to talk about HIV. Next slide, please. So this is kind of what Laurie was talking about earlier about this vicious cycle, if you will. And when we do loneliness work with people with HIV, we have to talk a lot about stigma. And we have to talk about the secrecy that comes from living with HIV. I've had patients and I've had research participants who would tell me, "You're the only person who knows I have HIV." And that secret, keeping that secret, must be a really heavy burden for a lot of people to handle. So, people get into this cycle where, they have, maybe they find stigma, you know, HIV related stigma in the community, and then they have their own self stigma that leads to secrecy. They cut their contacts, they don't want anyone to know. It leads to isolation. And then a whole lot of psychosocial problems happen when people are lonely and they feel that they don't have anyone to talk to. Next slide, please. So here's another thing that we have to think about, and this is something that Laurie and I have talked about when we imagined using her intervention of Listen for people living with HIV, because when people get lonely, there's a lot of studies who show this. When people get lonely, their adherence to their HIV medications decreases. Okay, and we know when your adherence isn't good, that increases your viral load, which decreases your T cells or your CD4 count. Okay. And all of these things, of course, your high viral load, your low CD4 count, they all lead to possible illness or possible early death from having uncontrolled HIV. So we are interested when we want to do work with the loneliness intervention Listen, we want to make sure that we are not only impacting loneliness, we're impacting HIV self-management. How do people manage their illness, including their adherence? Now, HIV care has progressed leaps and bounds since I started working in HIV care. Now we have, you can get an injection for your HIV medications, and adherence is not, what it used to be with the number of pills and everything. But still, when you're lonely, you're more likely to forget to take your medications. And so we have to build that piece of HIV self-management into this care and treatment, into HIV care and treatment. Next slide, please. All right. Some special populations that we have to talk about: loneliness and people living with HIV. And I think one of the groups that sometimes gets left out, and I know I'm talking to people 50 and over here, but let's not forget about our young people, all right? Because they're the future. And the young people living with HIV, whether they, acquire it, perinatally, mother to child transmission, or they acquire HIV in adolescence, they have a lot of loneliness too, right? And I did a study years back of perinatally acquired people living with HIV. And a lot of the things that they talked about was this fear of disclosure. They didn't want anyone to know their HIV status, So it was a real challenge to get them to, find someone to disclose to. And I understand completely. I understand their fear of disclosure, because some of them did tell us that when they did disclose to people, sometimes the reaction wasn't what they wanted, right? Relationship challenges are a problem. You know, it's for these young people, it's a challenge to try to date someone and, you know, navigate that whole adolescent period and sexuality, and then add in HIV on top of it. It really adds another layer for these young people. Okay. Youth-friendly care is a challenge. We don't always, you know, sometimes we being older people, we don't relate well to these younger people, or they don't relate well to us. And sometimes some of that youth-friendly care is lacking. Okay. And then lastly, peer pressure. They get a lot of pressure from their peers. And sometimes, in order not to succumb to that peer pressure, they just isolate. Right. So that's a population that I want us to always keep in mind. Next slide, please. And of course, our loneliness and older people. Okay. So we know by statistics that over half of people in the US who are living with HIV are 50 and older. Okay. Now, I don't like it when people say 50 is older, all right, because I'm in that age group too. So, you know, we don't like to admit that we're older, but anyone over the age of 50 is considered an older adult, right? So here's the thing, here's the challenge for people living with HIV who are 50 and older. You get what's called the double or triple challenge. Not only does you have HIV, you may have other chronic illnesses. We know the older you get, the more likely you are to have other illnesses, diabetes, hypertension, all of these other type of factors. And then you're not only managing HIV, you're managing these other chronic illnesses. So that becomes a challenge for people with over 50 living with HIV. And also, those who survived and lived through the early days of the HIV epidemic experienced a lot of losses, right? There were partners, friends, co-workers who died of HIV back in the days when there was no treatment. And over the lifespan, you know, losing those people, those history of multiple losses, it increases one's risk for loneliness. Right? And there's a lot of studies that say that. All right. So we were interested, our team, and Laurie and I are on this team with a couple of my other co-workers here at the University of Miami and a PhD student. We wanted to see what intervention studies were out there to address loneliness among older people living with HIV. Now, we were only looking at older people. We weren't looking at younger people. We were just looking at the older people. We only found 9 studies, okay? And these studies really showed mixed results in decreasing loneliness. Some of them did a great job in decreasing loneliness, but some of them did not, all right? And also, there was really a lot fewer studies of older people living with HIV that focused on helping them decrease their loneliness while manage their illness, okay? And Laurie and I were like, aha, this is where we think this listen intervention can help, okay? Because it has that self-management of illness piece that we may have to adapt a little bit for people with HIV, but we think it's there. And then also the other thing that we noticed with these studies is very few of them used technology to deliver interventions. Okay, now we know after COVID, people showing up to things in person are less likely now than they were before COVID. A lot of people don't want to travel. And if you live in big cities, or even if you live in a rural area, it might be farther for you to travel. But even in big cities where there's public transportation, it may take you an hour to get from one side of the city to the other. And do you really want to travel that far for an intervention? So we think that Listen is the perfect intervention for older people living with HIV, and we think that we could use technology to deliver this intervention. All right, next slide, Laurie. And I'm wrapping it up here. Again, I was already talking about listen. I already gave it away here, but we think that Laurie's intervention could be a potential one. We also think it could also be used with younger people. As Laurie said, her team has done work with younger people. And also, I've given a few presentations in the Fort Lauderdale Wilton Manors area, and I've also had a few people say, well, in addition to older people living with HIV, I think we need an intervention for, gay and bisexual men. There's a lot of loneliness in gay and bisexual men. So the listen intervention also could be a potential intervention there. But here's our problem, all right? We need funding for this intervention. As Laurie mentioned, we've applied for a couple of grants to fund the pilot work, to adapt the intervention and pilot test the intervention. But the funding wasn't there. And right now, in the current funding climate, there's very little funding for HIV. There's some funding for aging, which we could tap into, but we want to start small and, do our pilot work first before we go after the bigger, NIH grants for this. So if anybody wants to donate money for this, we accept. I'm just kidding about that. But, every time I go to these talks and I give a talk like this, I always say, if any organization wants to fund something like this, we would be very interested in working with them to kind of do the pilot work on this intervention. So we're both open to, and committed to the population and to the study of loneliness. And I think that's my last slide. Oh, I think this is, or is this your slide?
I had one more slide in here. I was going to show them. There it went. So I did want to show you all too, this last slide. Sorry about that. We had some extras in the slide deck, but these are some national and global initiatives. If anybody is interested in going to any of these other sites just to learn more about loneliness. And I did want to tell you too, the last thing on this slide is the I Belong program. That's my website, listenforloneliness.com. It does have some information on that website about Listen, and also a new program I'm looking at called I Belong. So I'm happy to talk about that another time, but that's the last slide. Yeah.
Great. Thank you so much for these thought-provoking presentations. We're going to move now to the Q&A portion of the call. I see that there's several questions coming in, both on the chat and through the Q&A part of the Zoom, and so I'm going to do my best to grab all these questions. We have, let's see, first question that I'll present to either speaker. In what ways can society utilize people aging with HIV's wisdom and skills to make them feel valued and included, considering that more than 53% of this population are aged 50 plus?
Well, I'm going to probably let Joe answer that to a certain extent, but I am a family nurse practitioner. I'm also a clinical specialist in geriatrics, and I spent about 15 years working solely in an aging clinic. And so thinking about how we could best use the wisdom of people with people with extensive experience, I think that aligns with our need to sort of honor and respect the developmental phase of people as they age, right? Where we're seeking integrity and we're seeking being validated and we're seeking being valued in society. And that's a very deep question, because it culturally sometimes that doesn't happen in the United States. And in other countries, I think it happens in different ways. And so I think we would need quite a cultural shift in this country to make sure we are honoring our people as they age and respecting their wisdom and experience and what they could bring to younger people. There are some sort of intergenerational initiatives happening, but I'm going to let Joe talk if there are any specific to HIV.
Yeah. Thanks, Lori. I think I'm a pediatric nurse practitioner and a clinical specialist in child psych. And so I worked with a younger population, and I would say the older population could very much be role models for younger people living with HIV. Because as I mentioned earlier in the presentation, a lot of people, a lot of young people living with HIV don't know other people living with HIV. And maybe having some type of mentorship program where you would match an older person with a younger person living with HIV might be something to explore. And that way you could use the wisdom of older folks, combined with that, the youthfulness. Also it's fun to be, when you're older, it's fun to be around younger people. And so I think it could be like a mutual support program.
And the only other thing I'll say about that is if we are successful and if we can kind of get Listen off the ground on a regular basis, and I'd like to deliver it online in groups of like 3 to 5 people at a time. I do think when we did Listen before with other groups, we did it on the common experience of having an illness. It wasn't on the common experience of being old or young. And so having multiple generations in those groups could actually really be helpful. And I also think that intervening with loneliness is just when you see 60% of people with HIV have loneliness, like it's obviously not something that we can just, that Joe and I could run, right? But I designed Listen so that it didn't require a healthcare provider to run it. And the
Yeah.
older adults that have gone through Listen have told me they think they could run a Listen program at their church or run a Listen program at different organizations. And so lay people could deliver Listen in communities. And I think older people living with HIV might be the perfect people to do that and bring in groups of younger people and help them understand this experience of loneliness as they live with this illness. So that's something we could think about.
Absolutely. Yep. Mhm.
Okay, thank you. There is a question specific to the listen intervention, which is how does the listening intervention work in a fast AI digitized world?
Yeah, I know we do live in that fast AI digitized world. It's true. But, sometimes that world isn't the best thing. I think um, I will tell you that loneliness is a hard problem to solve, and Listen solves it because it honors the process of cognitive restructuring. And so I don't think when you're deep into an experience of loneliness that you can kind of solve it super quickly. I do think it takes some time. Listen is structured so that we did 2 hours a week, and then each session had not only homework but also some daily some writing accompanying it so that you could sort of process through the first week and then come up with homework and come in ready for the next week. So, for example, the first week, I can give you an example. The first week of Listen, we focused on belonging and not belonging. And people not only talk about their experience of belonging and not belonging, but they also write about it. And then we give them some homework that says, okay, think about what we've discussed this week and come back next week ready to talk about relationships and bring something that illustrates your experience in relationships. And it was really so fascinating. We had people bring everything from stuffed animals to their walking shoes, different things people would bring to the group. But my experience is that people needed that week to process what they had discussed in the first week and get ready for the next week. So I don't think the problem of loneliness is not something we can solve quickly in a digitized world. Even with my I Belong program, I actually added a week. The I Belong program is sort of a self-help program that you can walk through and do some of the similar steps of Listen, but come up with micro actions or actions you can take to heal your experience of loneliness. But when you're deep in loneliness and experiencing that stigma and chronically ill, it does take some time to figure out what you need, what your capacity is to heal that problem, what actions you need to take, and how you step forward. So it's just not something that can be quick. Now, I will tell you this. There's all these little other little things that people have tried, like For example, the Yaya Bear was the one thing we sent a proposal in for long-term care, which is an AI-enabled bear. It's a tech solution. The portals, video portals at the home for older adults. People have tried that. There's a little robot people are trying. There's a seal robot that people are trying in long-term care. Those things, we know in the moment of loneliness, if you interact with something that's AI enabled, if you don't have another person there, it does in that moment help you to feel less lonely. It's not necessarily sustained, but you know, I think we have to think about, can we heal the problem and can we also help people be better on a day-to-day basis? So I'm kind of open to all of it as part of a comprehensive plan of what a person might need. And again, that plan has to be a little bit determined by the unique individual.
Great, thank you. And there's quite a few questions that are coming in. Let's see. There's a question here about how we can integrate standardized loneliness and isolation screenings into routine HIV clinical care.
Well, I can give you a couple examples. So, like in the Epic healthcare record system, we do have a social isolation scale in there now. And there's also, we could easily put in like the UCLA 11 item. I like the 11 item scale, and it's a whole thing. There is a 3 item, and I know it's less burden, but I think you get more variability on the 11 or the 12 item. But those kinds of scales can be actually put right into these electronic health record systems, just like a depression scale or an anxiety scale. And I think we're at that point in healthcare. You know, when we are treating people for depression or anxiety and we know they're lonely, if we had recognized their loneliness earlier, we may have been able to prevent that occurrence of anxiety and depression. So just building in some of these reliable and valid tools, which, by the way, the National Academies of Medicine and Science, you know, has a great report. It's about 250 pages on loneliness and social isolation in older adults. It has a whole chapter with all those instruments in it. And so there are reliable, valid scales we can use and have built into specific modules in health records, if that helps. So.
I would add on to that anyone who's, depressed, anxious, non-adherent, they should definitely get some screening for loneliness in HIV care. So I think that would be, you could do it for everyone, but if your clinic didn't have the capabilities to screen anyone, I would definitely look for, the high risk people, those who live alone, those who, maybe have immigration problems or they're depressed or anxious. I would definitely screen them for loneliness in addition to the other things that we screen them for.
Yeah, I agree with that, Joe. And it's nationally recommended from the U.S. Preventive Services Task Force that we screen every adult anyway in the country for anxiety and depression. And usually they'll use like that GAD-4, which I also think is not enough, but we use it. But the one tip I want to tell people about screening is this. In every single study I've done, we have also asked people the single item question, do you feel lonely? And all of our studies show that even people with high loneliness scores often do not say yes to that question. It's too direct. And so I wouldn't recommend just saying, hey, are you lonely today? I would say, can I ask you a few questions and see how they do? Because it has to do with that stigma. And while people don't self-disclose, you can pick it up on a scale. And then once they've done the scale, often I'll say, hey, do you know your loneliness scores came out pretty high? And then we can have a conversation about what they need. But asking directly might not get you the answer.
Thank you. There's a question here about institutional loneliness. So, as the golden generation of survivors ages, how do we prevent a new wave of institutional loneliness in nursing homes where staff may be uneducated about HIV?
Ooh, Laurie, that's your specialty.
Yeah, I mean, this is a crazy, I'm going to tell you, this is a real, I don't want to say crazy problem, but this is a big problem in long-term care. We are currently looking at loneliness, and is it even more likely to make you land in a long-term care facility? And then in the long-term care facility, you're even lonelier. And during COVID, we saw a nightmare happening with long-term care and loneliness, right? So it really highlighted the problem. We are looking to partner with long-term care facilities. I have put Listen out there. Of course, I'd be happy to run listen programs. I actually think listen could be part of clinical care and long-term care facilities. We do know that the experience of loneliness, I have a student who's actually just done a concept analysis on social connectedness in long-term care, and we know that social connectedness looks different in long-term care settings than it does out in, like, say, community settings. And so figuring out, would listen work, and could it be part of clinical care delivered there, like through activities directors or other people in the nursing in long-term care? I think it would be really valuable. I think nursing homes, a lot of nursing homes are asking the question now because we have had some more interest from long-term care. So they're asking about what they can do about loneliness for people, but we've yet to have a program adopted. And I think, having a solution that hasn't been adopted is really one of those things that Joe and I, that, really I've struggled with, is how to get it out there. And people seem to want to develop their own solution, but oftentimes when you do that, it's setting specific, not precise to loneliness. And so, for example, I had an insurance company one time want me to design a solution for them, and I wanted that. I'm like, we have a solution, and let's put it out there for like Medicare users. But I do think we could definitely use listen in long-term care, and the problem is real, and the subpopulation of people with HIV in long-term care is understudied, and I think definitely would require a little bit more education for nursing home staff.
Yeah, the other thing that we have to think about with older people living with HIV, um, or older people in general going into nursing homes who are LGBTQ plus people, sometimes when they go into nursing homes, they have to quote unquote go back into the closet because they're afraid they're not going to be accepted in these long-term care facilities. And that could also increase their loneliness. So we have to think about those things too.
Um, there's a specific question also about listen. Is there a training one can go through to do a listen program, and is it possible to do listen virtually?
Well, we have proposals submitted to trial listen virtually. I think you could do listen virtually because we could just do it on Zoom. Because, I've delivered it multiple times in actual face-to-face rooms. And the issue with that is, like, when you have people with functional impairment, for example, our study of stroke, people had trouble getting there. So that is that is that. Is there a training manual right now or a program that you can buy? Uh, Listen is well documented, but there isn't a training manual because we actually haven't put it out there as being a purchased program. I guess we could do that. We were hoping to study it a little bit more and see if we could deliver it virtually, but yeah, I mean, putting together a training program and marketing it that way would probably have to involve some funding as well, or we would have to make it a sellable product. So I could think about that though. I hadn't really thought about that. We were thinking of doing it more as research study based, but I actually think it would be so good to just implement it, in some different settings and see how it does as well. So I would be willing to train people how to use it and see if how they did. I mean, that's something I've actually done it pro bono with other people. Like, I had a student in South America that used it with some college students, and I just sort of gave in-kind support, so that she could run it and
Mhm.
see how they did. So yeah.
Yeah. And Lori, if we do run it with HIV for people living with HIV, I would love to do it with a co-facilitator who is a person who's living with HIV and who's experienced loneliness,
Yeah.
so that they can give the real world perspective that you and I can't give.
Right. And somebody that could maybe continue to deliver it,
Mhm.
after we see how people do. So also, it's like, um, I think we're sort of in that mindset, that it could be taken to the communities. Yeah.
Great. Thank you. Another question about the listen intervention. At the NMAC Biomedical HIV Prevention Summit, my presentation highlighted how AIDS survivor syndrome often comes with profound medical mistrust, making it hard for long-term survivors to connect. The story-based approach of the listen intervention is a beautiful counter to this. When utilizing listen or similar narrative interventions, how do you help older adults overcome those initial trauma walls so they feel safe enough to actually share their stories?
Sure. Yeah, that's actually, we do that using the suggestion from actually a mentor of mine, who was a senior nursing faculty member who actually wrote story theory. So she was the author of Story Theory for Nursing. And she suggested what we do is we have people before they talk engage in some quiet, continuous writing. And it actually did help. It really did work. And so we will have the discussion topic there, but we will have people write first for about 10 minutes, sort of quietly write or journal about their experiences related to the discussion topic. And I think that was really helpful because then when we got into some discussion, people were able to, they've released some things onto the paper, and I think they were better prepared to discuss, and they could bring up things they wanted to bring up and maybe not bring up things they weren't quite ready to bring up. But that having that moment of quiet where everybody was, we're just going to think about this for a moment and do some writing, really helped people to center their thinking on the topic of the day and think about what they felt comfortable sharing. So that's what we did for that, if that helps. So mhm.
Thank you. I know we're getting close to the hour here, so I'm gonna ask a broader question, which is from the Q&A, which is it time to reframe loneliness not as a mental health symptom, but as a clinical comorbidity that accelerates physical aging and inflammation?
That's the best. Yes, and it has been for 10 years, absolutely. Because, it wasn't until, first of all, I want to say there was not an ICD code, a medical diagnosis, a nursing diagnosis approved through NIC, and there was no way to document a diagnosis of loneliness and get paid for treating lonely people. So, and still to this day, it's very difficult. Recently, now there is some diagnoses related to loneliness that you can actually document the diagnosis and care for it so that people can get reimbursed in a sense. And that has always been the limitation, is taking loneliness from what people viewed as a social problem. It was always conflated in the social science literature as a social problem, and bringing it to the real world of this is a real healthcare problem, and having medicine and science and nursing and social work and everybody embrace it as a health problem that healthcare providers are responsible for diagnosing and treating. That's where we hope to go with this. That's where we've been hoping to go. There are now some ways to do that. But yes, that's exactly right. Mm-hmm.
Great. Thank you so much. Moises, I think that about wraps up the time we have for the Q&A. So I'm going to turn it over to you at
Sure.
this point. Thank you.
Yes. This has been excellent, and I'm very grateful, and I'm sure all the participants in the webinar are as well. There has been, I really appreciate how approachable you made yourself and how clear your presentation was in terms of like not a lot of scientific jargon, but like something that people can follow and make them think about. So, I mean, I hope this is just the first of many opportunities to collaborate with the three of you. And thank you for your presentation. Thank you for the participants for engaging, for putting questions in the Q&A box. I think that clearly the audience show that they were very receptive, and it made them think about many of situations that they face. So please remember to the participants to complete the evaluation. It's important for us to continue do these kind of webinars. And also you can complete it at a link. I don't know if the link is showing here in the chat, Dree or Taylor. Yes. Okay, so please go to that link and do the evaluation and let us know what you think. And we can keep bringing more presentations, like a second part of this presentation. I mean, I'm sure there is plenty to learn and share. So with that, please be in the look for the materials. We're going to distribute them with the recording. And again, I want to thank Nicole for an excellent facilitation of the event. And I'll see you next time, and have a great afternoon. Thank you.
Thank you.